Hello. First, I would like to thank the organization committee for the invitation to participate to this new sessions of the PHC. And I would like to talk to you about new insights in acute and chronic liver failure. I have no conflicts of interest for this presentation. Well, the natural history of cirrhosis is generally represented by a phase of a compensated cirrhosis, which means no overt complications, and then a second phase, which is the phase of decompensated cirrhosis, and this phase is characterized by the occurrence of complications such as ascites, encephalopathy, or bleeding. And each time one patient moves from one step to the other step, of course, life expectancy tends to decrease. But this representation of the natural history of cirrhosis does not take into account a particular presentation, which is characterized by a stable situation, compensated or not, which can last for months or years, and then a very rapid deterioration with a high mortality, and this deterioration corresponds to the occurrence of extrahepatic organ failure. And this is basically the acute and chronic liver failure. So a definition of acute of chronic liver failure has been proposed in 2000 of ACLF, because there was different definition in the Asian Pacific region, and also different definition in the US. And ACLF is graded into three categories of increasing severity. ACLF grade 1 is corresponds to a single kidney failure or single failure of the liver, which is defined by an increase in bilirubin or decrease in coagulation factors, and within a certain range of serum creatinine. And a third part of the grade 1 is single cerebral failure with also a creatinine ranging from 1.5 to 1.9. The definition of ACLF grade 2 is more simple, 2 organ failures, and ACLF grade 3, 3 or more organ failures. So this is a relatively simple definition, except that ACLF grade 1 is homogeneous in terms of prognosis, in terms of mortality. All these groups of patients have a similar risk of dying, but it's not very intuitive, and maybe it should be revised in the future. Now, which are the definitions of each organ failure? 6 organ failures. Liver failure is defined by an increase in bilirubin over 200 micromole, kidney failure creatinine over 180 micromole, coagulation failure either INR superior to 2.5 or platelet count below 20, circulatory failure, the need to use vasopressors. Cerebral failure basically is grade 3 or 4 encephalopathy, and respiratory failure is defined by a value of PaO2 on FiO2 below 200. So these definitions are also clear and simple, but somewhat questionable because, of course, an increase in bilirubin may be due to causes other than liver failure, and coagulation failure may reflect liver failure, which results in an increase in INR. So again, there are some points which could be clarified in the definitions. Now, the mechanisms of ACLF are better understand, and clearly systemic inflammation is central in the development of organ failures in patients with cirrhosis. You can see here on the left that patients may have precipitating events, but not always, because ACLF can occur without any identifiable precipitating factors. And then the second phase is characterized by an inflammation with the release of PAMPs and DAMPs, which results in severe systemic inflammation and oxidative stress. There is an immune-mediated tissue damage, which is associated with the production of an increased production of NO and decreased effective arterial blood volume. And on the other hand, mitochondrial dysfunction, which results from a decrease in ATP synthesis. And all these mechanisms result in single or multiple organ failures. So the mechanism have also been further clarified with metabolomics, and a recent study has shown that there is a fingerprint with 38 metabolites which are characteristic of patients with ACLF. And these metabolites are related to intense proteolysis and lipolysis, extra mitochondrial glucose metabolism, decreased mitochondrial ATP production, extra mitochondrial amino acid metabolism, and production of metabolotoxins. The main problem with ACLF is that it is a vicious cycle. You have a patient with cirrhosis, then he has impaired liver function and portal hypertension. It is well known that now that cirrhosis is a state of systemic inflammatory state, and then comes a precipitating factor, but again, precipitating factor is not always present. And you have seen that immune-mediated tissue damage is central in the development of organ failures, but the problem is that once organ failures happen, so they result in further impaired liver function and sometimes an increase in portal hypertension, and this is the vicious cycle of ACLF. The mortality by definition of this condition is high. You can see here a comparison of patients with no ACLF, ACLF grade 1, ACLF grade 2, and ACLF grade 3. And in patients with 3 or more organ failures, as you can see here, early mortality is very high, with less than 20% survival at 90 days. The prognostic factors of ACLF can be defined by a score which is called CLIF-OF score, an acronym which represents organ failures with 3 levels for each of them. And the score also takes into account other factors than organ failures, namely age and white blood cell count, which is a reflex of systemic inflammation. The problem is that the prognostic value of this prognostic score is relatively low, 0.76 at 28 days. So how to exit the vicious cycle of ACLF? The first option is extracorporeal liver support, and the most widely used extracorporeal liver support has been MARS, which is albumin dialysis. You can see here the results of a control study which has been conducted in Europe. All patients with ACLF, 90 patients in the MARS arm and 89 in the control group. The MEL score was high in the 2 groups. Majority of patients had hepatorenal syndrome. The decrease in bilirubin was more pronounced in patients with MARS, which is logical because MARS is supposed to remove substances which high affinity for proteins such as bilirubin. There was a significant decrease in creatinine, which is not surprising because MARS is associated with the hemofiltration system, and a decrease in platelet counts, which is a well-known adverse event of MARS. But you can see here no difference in terms of 28-day survival. So MARS does not help to improve the prognosis of these patients. So the only way to exit the vicious cycle in very sick patients is rescue transplantation. And since ACLF has been defined, a number of studies coming from Europe or from North America have been reported showing that good results can be achieved with liver transplantation in selected patients with either a very high MEL score and patients in the ICU due to the need for mechanical ventilation, renal replacement therapy, or vasopressors, or patients with meeting the criteria for ACLF. And 1 year survival as high as 75, 77, 80% can be achieved in selected patients, but there are still discordant results concerning grade 3 ACLF, which is a situation at high risk in patients for liver transplantation, with good results reported in this recent European studies and more lower survival in another study. So ACLF in patients with 3 or more organ failures, in my opinion, still needs to be clarified. So we also have to take into account the fact that not all organ failures can be reversed with liver transplantation. Of course, by definition, liver failure is reversed by liver transplantation. Coagulation, of course, is reversed by the transplantation of a functional liver. Same thing for hypersplenism, which determines thrombopenia. Neurological encephalopathy recovers after liver transplantation. Kidney failure is improved in in most cases after liver transplantation, but not in all patients, and sometimes only partially. Circulatory failures improve in patients after liver transplantation because circulatory failure is characterized by the hyperkinetic state of cirrhosis. But by contrast, bilateral pulmonary infiltrates, except in patients with isolated fluid overload, represent a very important risk factor, a very high risk mortality in these patients. So not all organ failures have to be considered in the same way in the selection of patients. And in the selection of patients, we should also take into account important factors, which are age and, of course, comorbidities, diabetes, obesity, and so on. So prevention is better than cure, and very recently, the results of a large European observational study, which is termed PREDICT, have been reported. This study included more than 1,000 patients with acute decompensation of cirrhosis, but no ACLF, and 3 groups of patients were identified. Patients with pre-ACLF, namely a group of patients who developed ACLF soon after inclusion in the study. You can see here the ACLF is in green, and high mortality rate here in blue, and the mortality comes relatively early after inclusions of these patients. The second group is termed unstable decompensated cirrhosis, which means patients who do not meet the criteria for ACLF at any time, but have a high rate of infections and relatively high rate of mortality. And the third group is termed stable decompensated cirrhosis. These patients have a high rate of infection, but they do not develop organ dysfunction, and organ failure, and they have virtually no mortality. And these 3 groups are clearly different in terms of systemic inflammation. And when you see CRP, which is a general marker of inflammatory state, the level of CRP increases quite linearly from patients with stable decompensated cirrhosis to patients with ACLF. So again, systemic inflammation is central as a mechanism of organ failures in cirrhosis. So in conclusion, ACLF can be defined by cirrhosis associated with organ failures, and this definition helps standardize definitions and compare populations. Systemic inflammation, oxidative stress, decreased ATP production are central in the development of ACLF. Multiple organ failures in the context of ACLF may result in a vicious cycle, which is not reversed by conventional therapy and extracorporeal liver support devices. So salvage transplantation is possible in selected patients with ACLF, but not all organ failure weigh equally on mortality. And of course, in the selection of patients, we have to take into account age and comorbidities. And finally, inflammation level and course of inflammation is a promising tool to identify patients at risk of ACLF. Thank you for your attention.